Hi, my name is George Verdejo, and I'm Director of Vascular Ultrasound Services at Montefiore Medical Center in New York City. And today I'll be discussing with you the use of duplex ultrasound for evaluation of the aorta, iliacs, femoral popliteal, and tibial arteries. Hi, my name is George Verdejo, and I'll be discussing the use of duplex ultrasound for evaluation of patients prior to various endovascular and open arterial procedures. Our objectives today will be to discuss the history, rationale, and protocol for use of duplex scan assessment of patients with suspected peripheral arterial occlusive disease, to describe techniques for imaging of the lower extremity arteries, to identify common pitfalls of lower extremity arterial imaging, to provide tips and pearls for facilitating the examination and overcoming those pitfalls, and then we'll review a few representative cases. As you know, contrast arteriography has long been the gold standard for evaluation and imaging of the lower extremity arteries. Interventionalists and vascular surgeons have a long experience with this technique, and they've reached a certain comfort level with the images that are required. These images are easily interpreted and provide lots of detailed information, and also serve as a great surgical guide for the performance of lower extremity bypass grafts. Arterial duplex scanning, on the other hand, has traditionally been used only to confirm the presence of suspected peripheral arterial occlusive disease, or to confirm the presence of a lesion seen on some other imaging study. It was sometimes used to define the anatomic location or of stenotic or occlusive lesions suspected by other indirect testing methods. But traditionally, arteriography was used prior to all interventions, and duplex was really rarely integrated into the decision-making process. However, there are various reasons why one might move away from the more invasive contrast arteriogram, and I've listed here a few of those issues, all of which point to duplex ultrasound as a viable alternative for imaging the lower extremity arteries. The rationale for supposing that duplex ultrasound could be used in this setting is based really on two genres of studies in the literature. The first that evaluated the ability of duplex ultrasound to image the lower extremity arteries. In this study from Dr. Mineta, published in the Journal of Vascular Surgery of 1992, his team sought to assess the accuracy of duplex ultrasound to evaluate individual arteries and to detect greater than 50% stenosis and/or occlusion. They looked at 150 patients in whom they compared the duplex ultrasound to the contrast arteriogram results. Their results were very good. They showed 99% visualization at and above the knee, and a sensitivity for documenting greater than 50% stenosis that ranged from 89% at the iliac level to 67% in the popliteal artery. These results were equally as good in the arteries below the knee. Keep in mind that these results were obtained with technology that dates back to 1992, and with the exquisite imaging and technology that we have today, imaging of the lower extremity arteries has much more improved. This study from the University of Washington looked at 110 patients in whom they identified 50 lesions that they thought were amenable to percutaneous transluminal angioplasty based on the duplex scan results. In 47 of 50 of those lesions, or 94%, the patients in fact went on to get a percutaneous transluminal angioplasty. There were 3 cases where PTA was not performed because the procedure was thought to be technically difficult. The take-home message in this study, however, is that there were no percutaneous transluminal angioplasties done in patients found not to be suitable by the duplex scan. In other words, the results of the duplex scan did not exclude any patients from receiving treatment. Based on those studies, the landscape really was changed for us in the vascular laboratory, and the role of the duplex scan evolved really to pre-intervention imaging and/or mapping to determine whether or not a patient is a candidate for an endovascular versus an open approach. The goal was to identify the site of the lesion, to determine stenosis severity as well as the length of the lesion, and also to assess the status of the distal runoff. In these patients, a limited then intraoperative arteriogram can be performed, and then the intervention can be facilitated. In general, the idea was to detect and to localize severe disease and eliminate the need for routine diagnostic arteriography. With the evolution of the technology, we further sought to answer the question, was duplex good enough as a sole imaging modality prior to lower extremity bypass grafting? The group in Brooklyn, Dr. Asher's group, have been huge proponents of this technique in this setting, and they published a paper in 1998 titled Value and Limitations of Duplex Ultrasonography as the Sole Imaging Method of Preoperative Evaluation for Popliteal and Infrapopliteal Bypasses. And our own group, with Dr. Wayne as the lead author, published a paper in the Journal of Vascular Surgery in 1999 asking the same question. I'll very quickly go over the results of our study. We looked at 41 patients who were undergoing arterial reconstruction, all of whom had both duplex ultrasound and arteriography. The observers were blinded to the results of the angiogram and were asked to predict the operation and the anastomoses based on the duplex results. Those predictions were then compared to the actual surgery that was performed. The results are as follows. We were able to predict femoral popliteal versus infrapopliteal bypass in 90% of the patients, and in those patients we were able to predict the anastomotic sites in 90% of the patients. We were able to predict infrapopliteal bypass anastomoses in only 24% of the patients. And the primary issue in this case was the inability of the duplex to predict the preferred outflow tibial vessel. We felt that by duplex alone we couldn't really determine which vessel was best for an anastomosis based on the ultrasound image. Using techniques that I'm about to describe, we've been able to create arterial maps such as the one that you see here, and use these maps then to predict the type of intervention that would be most appropriate for the patient in question. This has allowed us to decide, again, what type of intervention is appropriate or even possible. These interventions can range from endarterectomy to bypass, angioplasty, thrombectomy, lysis, and in some cases, conservative therapy when the results of the duplex scan show that really no viable interventional procedure was appropriate, and this has allowed us to avoid arteriography altogether. Let's quickly talk about some of the techniques for arterial mapping and just go over very quickly some helpful hints. One of the things that I like to say is that the technologist should get comfortable before the start of the examination. These exams can be quite labor intensive, can take up to 60 to 90 minutes to perform, and you really want to be comfortable before you get into the room. Get all the information that you need, all the equipment that is necessary in order to complete the examination. In general, we tend to do one leg at a time, and we inform the patient of such. If the patient requires a bilateral study, we tend to schedule the patient for another day. Use all of the information that's available, the waveform information, the velocity information, as well as the color flow image in order to create your arterial map. And then we use two other techniques, and that is a quick scan technique in the thigh and a bottom-up technique in the calf, which I'll elaborate on shortly. Very important is to create the arterial map as you go along. This is not the kind of study that can be easily reproduced at the end of a day after you scan 10 or 12 patients or so. There are just too many details to recreate at the end of the day. And so what we do is we create the map segmentally. As we evaluate the aorta to the aortic bifurcation, we would then go and create that map, evaluate the iliacs and create the map of the iliacs, then go on to the femoral popliteal segment, and then onto the tibial artery, scanning one tibial artery at a time and creating the map as we go along. Most examinations start at the level of the femoral artery. In fact, however, there is a set of patients, a subset of patients in whom evaluation of the aorta and the iliac arteries is necessary, and we have algorithms in place to identify those patients. Any patients with a decreased femoral artery pulse, with an abnormal femoral artery acceleration time, any patient with symptoms that are referable to the aorta and the iliac arteries will go on to get an evaluation, a direct imaging evaluation of the aorta and the iliac arteries, and we have a low threshold for evaluating these patients. NPO is a plus minus. We don't typically find that we need to have our patients be NPO. However, if that segment of the arterial system is gassed out, we will reschedule the patient after having the patient be NPO overnight. Typically, we use low-frequency transducers as these vessels tend to be deep for evaluating the proximal vessels. However, we find that this is not always necessary, and my recommendation would be to use the highest frequency transducer available that allows you to see all the vessels of interest. The aortic bifurcation is best seen with the patient turned to his or her left and with the transducer position just in front of the right iliac crest. And if you do that, you can produce images such as the one that I show here with the aorta and the right and left iliac arteries very nicely seen. In order to evaluate the the common and the external iliac arteries, you may have to turn the patient into a lateral decubitus position with the side being evaluated turned upwards. My preferred method of evaluating the iliac arteries, however, is to start at the groin level using a linear array transducer and then to follow the arteries proximally to the level of the aortic bifurcation. Either one of these techniques will work, and occasionally we'll use combinations of both techniques. The examination is then carried on through the femoral popliteal segment, where the common femoral, the origin of the deep femoral artery, the femoral artery in the thigh, and the popliteal arteries are evaluated. Keep in mind that in most cases this will be the most common area for disease, and this is that area where we use the quick scan technique first. And what we'd like to do is turn on the color flow image, and using the color flow image alone evaluate the common femoral artery down to the level of the popliteal behind the knee to get a quick scan and scout the area before we go in and start to acquire all the Doppler and 2D images that are necessary to create the map. I think this saves quite a bit of time because it very quickly allows us to image stenoses and occlusions where they may be present. We use the color flow map as a guide. We also mark stenoses and occlusions as we see them, and we measure the lengths of those stenoses. A good tip here is to use the veins as landmarks. As you can see in this patient, the knee has been bent and the leg has been externally rotated to give us access to all of the vessels of interest from the level of the inguinal ligament down to the knee. The patient is in reverse Trendelenburg in order to allow blood to pool in the veins and allow us to use those veins as landmarks to identify the arteries of interest. If you're going to have any issue in terms of imaging the lower extremity arteries, it'll probably be in the area of the distal thigh where the superficial femoral artery becomes the above knee popliteal and tends to dive deep into the musculature, and then again at the level of the proximal calf where the tib perineal trunk and the perineal artery can be quite deep. In these areas, you can turn the patient on his or her side, or perhaps turn the patient prone and evaluate the above knee popliteal and perineal arteries from the back. You can also opt to use a lower frequency transducer to image these deeper structures. Our next stop would be the tibial arteries, which we evaluate again from the level of the popliteal artery down to the ankle. This would probably be the most difficult and time-consuming part of the examination, especially in patients with multi-level occlusive disease that will result in low flow velocities. It'd also be difficult in patients with diabetes in whom there may be a lot of calcification. The vessels of interest are the tibioperineal trunk, the anterior and posterior tibial arteries, as well as the perineal arteries. You want to use a low PRF and a narrow color box in order to facilitate the color flow image. In this area, we use a bottom-up technique, and that is we start evaluation by identifying the tibial arteries at or near the ankle. They tend to be very superficial, relatively superficial here, and easy to image and visualize, and then follow those vessels up. Keep in mind that if the patient is a candidate for a distal bypass graft, you would not want to bypass above the level of an occlusion, and so imaging from the top down only to run into an occlusion might result in a lot of wasted time. So again, we start from the bottom and work our way up in these vessels, although we do image the entirety of those vessels. We assess those vessels for patency and as well as for quality in terms of a target for a distal anastomosis site. It may be difficult to quantify stenosis in these vessels, again, as in patients with multi-level occlusive disease, the drop in pressure from those multiple lesions above that level may make it difficult to elicit a focal area of increased velocity at what may be a hemodynamically significant stenosis. The examination is then carried out excuse me, to the level of the pedal vessels, where we evaluate the distal anterior tibial artery, the dorsalis pedis artery, and the posterior tibial artery as they enter the foot. These vessels, again, will be very superficial. You want to use high-frequency transducers. Be careful not to apply too much pressure over these vessels as, again, in these low-flow situations, any pressure at all may compress the vessel and make it appear as if the artery is occluded. Pay close attention to flow direction at these levels, as you may be fooled into believing that an artery with flow that's moving in the wrong direction, in fact, is patent, and you may have missed a stenosis or a significant stenosis or an occlusion above that level. Bypassing to that artery above that level could result in graft failure. So flow direction is important. And again, in terms of the distal leg and in the foot, you want to mark any areas that appear to be best for an anastomosis. You may run into some problem areas. Of course, the pelvic vessels, because of their depth, may be difficult to visualize. We find that using multiple approaches and the appropriate transducers allows us to better image these vessels. The adductor hiatus, where the superficial femoral artery dives deep into the musculature and becomes the above knee popliteal, can also be difficult to image and evaluate. Again, multiple approaches, using a medial approach to image the distal SFA, and then imaging from the back, the above knee popliteal, working from the at-knee level and working proximally to overlap those areas will help to make sure that you evaluate the entirety of that vessel. The popliteal trifurcation, of course, can be deep and often difficult to visualize. We find, again, using low-frequency transducers can help. That can also be of assistance in terms of imaging the perineal artery in the calf. There is a segment of the anterior tibial artery just beyond the origin that will not be visualized as it crosses through the interosseous membrane. In this case, you'll want to use combinations of Doppler both above at the origin and then beyond the interosseous membrane on the lateral aspect of the leg to evaluate the anterior tibial artery. Significant changes in the waveform should clue you into the possibility that there is something going on in that segment that's not visualized. Be careful with the dorsalis pedis artery at the extensor crease, especially if the patient is in plantar flexion. Again, in these low flow states, compression of that vessel may fool you into thinking that the artery is occluded. Just quickly have the patient dorsiflex and reevaluate that area to confirm patency or occlusion if occlusion is suspected. Let's just go through a couple of cases where we've used these techniques. In this case, a patient came down for evaluation in whom we identified a very large popliteal artery, occlusion in this case of the origin of the anterior tibial artery with reconstitution distally. And as you can see here, the distal perineal and posterior tibial artery are occluded. And this is the corresponding arteriogram in that patient. As you can see here, the popliteal artery is a ragged-looking artery. Of course, you only see the lumen here in this patient with a lot of clot within the popliteal artery aneurysm. Distally, we can see that there is a patent anterior tibial artery which correlates very nicely with the duplex scan. It's occluded at its origin. The perineal artery is not visualized, it's occluded, and the posterior tibial artery is not seen. This patient went on to get 2 vein grafts, an interposition vein graft for repair of the popliteal artery, and a distal vein graft down to the distal anterior tibial artery for repair of those issues, and with a very nice result. And again, this shows the power of the duplex scan in this setting in patients who are contraindicated for large contrast loads. Here's a patient who presented with multiple occluded prosthetic grafts in whom we performed a duplex mapping which showed a patent common femoral artery, occlusion of the distal superficial femoral and above knee popliteal, with really only one vessel run off through the perineal artery and reconstitution of the posterior tibial artery distally. And this patient went on to get a vein graft to that perineal artery, which reconstituted the distal posterior tibial artery as predicted by the duplex scan. Just want to close with a little bit of some philosophical thoughts. There is a little bit of controversy out there about the appropriate use of duplex scanning and physiologic testing for the evaluation of patients with suspected peripheral arterial occlusive disease. And these are just some excerpts from the University of Vermont FlowNet. And one person asked, how does everyone out in the FlowNet land evaluate your patients with arterial disease? She followed up with a second question after multiple responses, some of which were contradictory, asking if arterial duplex is more precise than an ankle brachial index, and an ankle brachial index is included. Why do labs use lower extremity PVRs? This seems like an extra step and another extra cost to the patient. And really, they aren't. And my response to these questions were that the tests are not competitive. There are many scenarios for which a duplex and a physiologic test would be complementary and therefore appropriate at the same setting. And the bottom line really in these patients is that every good examination starts with a conversation with the referring physician to elucidate the rationale for the examination. In addition, your best bet is to assess every patient as an individual and perform the tests or tests that are most appropriate given the patient's history, the physical examination, the clinical presentation, and the question at hand. At Montefiore, after a physiologic test confirms the presence of peripheral vascular disease, we then use the duplex scan to map the lower extremity arteries in patients in whom an intervention is being considered. This is the first step in the treatment plan. We feel that the combination of physiologic testing and duplex scanning, where it's appropriate, helps us to utilize our resources more appropriately and not allocate the resources for imaging studies where a physiologic test is enough. We believe that this approach also allows us to minimize the use of diagnostic arteriography, but more importantly, in some cases, it obviates the need for an unnecessary arteriogram in patients who would not be candidates for interventions based on the duplex scan. And this currently is our algorithm for evaluation of patients for suspected peripheral arterial occlusive disease. The patient is referred for testing and a physiologic test is performed. If that physiologic test is normal and the patient does not have exercise-related leg symptoms, the patient is discharged to home. If the physiologic test is abnormal, the patient goes on to have a duplex ultrasound if an intervention is being considered. If there's no intervention being considered, the patient can be discharged home with or without the duplex. In a normal study, in a patient who has exercise-related leg symptoms, a stress test is performed. If the stress test is normal, the patient is discharged home. If the stress test is abnormal, a duplex ultrasound again is performed if the intervention is being considered. If no intervention is being considered, the duplex is a plus minus and the patient is discharged home. I hope that this has been helpful for you in terms of your evaluation of patients with suspected peripheral arterial occlusive disease, and I'd like to thank you for your time and attention.